Professor Sam Janes, who is a professor of respiratory medicine and head of the respiratory research department of UCL, vice chair of the National Clinical Expert Group on Lung Cancer in the UK. Professor Janes has been working in the field for many years in lung cancer pathogenesis, treatment on lung cancer, and started to develop cell therapy to this goal. He was awarded a Wellcome Trust Senior Clinical Fellowship some years ago, and he also was awarded the First in Man Award and was awarded a Wellcome Senior Fellowship. I think he will talk to us about some other approaches to kill lung cancer cell. Professor Janes.
Great. Thank you so much for the kind introduction and invitation today. So I'm going to talk about mesenchymal stromal cells, so a change in gear for the last talk of the day. I must thank, before I forget, because I'll be panicking and just desperate to finish at the end. So I'm going to thank the funders of this program first. So actually, this started off with an MRC clinical training fellowship, which you'll hear a little bit about. And then actually the Wellcome Trust took on me as a senior fellow. And then finally, we've gone back to the MRC for the funding of the clinical trial that you'll hear about. So my story, I was actually a PhD student in Fiona Watt's lab. She's an epidermal stem cell biologist. But we were just down the corridor from Dominique Bonnet. And I was really intrigued at the time. There were many stories coming out in around 2000, 2001 about bone marrow stem cells becoming epithelial cells through processes of transdifferentiation. And I was really interested in sort of regeneration of the lung at the time. So I got together with Dominique and said, look, can I put some of your MSCs into mice and we can see what they do in the lung? And actually, we developed this a bit further, so we would actually get her MSCs to express lentiviruses expressing genes. And one of the genes that's particularly helpful in experimental studies was KGF. And this was seen to sort of overcome fibrotic lung disease in mouse lung in particular. So this is actually one of the first experiments I did with Dominique, and we injected the MSCs. So the MSCs are carrying GFP, and you can see them scattered throughout the lung 24 hours after injection. So this is basically what happens to MSCs when you inject them, almost certainly in humans as well. And that is they basically impact into capillaries. So this is a little capillary in the lung parenchyma, which you shouldn't really be able to see, but you get a cluster of 4 or 5 MSCs, they impact. And actually, they're really quite mobile. So you can see one here undergoing a sort of transmigration out into the alveolar space, almost as though it were a macrophage. So is my microphone still working? Yes, I think so. So we didn't see any effects on the lung in the disease, and we certainly didn't see any transdifferentiation into epithelial cells. But at the time, this paper came out with a couple of others, and I thought it was absolutely beautiful, and I was just starting at UCL as a sort of lung cancer chest doctor. So this is a glioma model. So there's a glioma in a mouse, a little satellite nodule of tumor here. And what this team, led by Nakamizo et al., did was they injected MSCs carrying a red dye, and in this experiment, they're actually injected into the contralateral carotid artery. And after a time, what they do is they take out the glioma and they show the red MSCs in the glioma, whilst in a normal area of brain, there are no MSCs. So this is suggesting that the MSCs are either homing or migrating or preferentially sort of liking the microenvironment of cancers and surviving. So the next experiment they did, I thought, was equally as amazing. And basically, this time they directly injected stem cells into the other side of the mouse brain. And here, for the first time, they really do suggest that these cells are homing across to a tumor. So they're actually attracted into the tumor. So as I said, I'm a lung cancer doctor. Lung cancer is a miserable disease. You've just heard about it from Prasad. This is old data now, but it hasn't changed. Basically, the 10-year survival of lung cancer is still about 5%. And unless you detect it early enough for surgeons like Prasad to take out, really it's still an incurable disease. It also accounts for about a quarter of all cancer deaths in the UK. So what my proposition was that we could potentially take lung cancer patients with metastases. We could inject peripherally MSCs, and these would probably lodge in the lungs. I've seen them lodge in the lungs, but from there they might home or migrate to the lung cancer and potentially lymph nodes and metastases, and we would deliver an anti-cancer payload. So a little bit about MSCs. So they grow really well. So that was another major attraction to me for using MSCs as a potential cellular therapy. There was more and more data suggesting that they did indeed incorporate into tumor tissue from around the globe. And then finally, I became interested in TRAIL. And I became interested simply because TRAIL appears to kill cancer cells, but tends to leave normal cells alone. So this is how TRAIL kills cancer cells. And actually, again, it's quite a good molecule for a lung cancer doctor, because TRAIL triggers the extrinsic death pathway through FAD and caspase 8, pretty direct pathway, whilst what we're using currently tended to be radiotherapies and chemotherapies. So that triggers the intrinsic death pathway, and we knew from experimental evidence that if you can trigger one, you might well highlight the other. So there was a possible synergistic effect to be had by adding in TRAIL. So that's when Michael joined the lab, and Michael was a bit of a career transforming recruitment for me as a first clinical fellow. He's now professor at the Brompton Hospital. And his project was very simple, just had 3 aims. The first was he had to engineer his MSCs to produce TRAIL, show, like Nakameso, that they did indeed incorporate into tumors, and then test it in a xenograft model. So we were indebted to Adrian Thrasher, who lent us his lentiviruses, and Michael cloned in a TET-on system, actually, expressing TRAIL and IRES-GFP. And he did the simple experiments to show the constructs were working. And actually, I always show this. So this is Michael's first ever experiment. So this was our lab's first ever lentiviral transduction of MSCs, of which, of course, our postdocs now will get sort of high 90s% induction. But it just shows, you know, a medical student coming in for the first time doing this type of experiment can use this system. So it's a really good system. The doxycycline work, there's a little bit of bleed through. You can see some GFP positive cells here in the no doxycycline control. So the next job was to put the MSCs expressing TRAIL in a dish with some cancer cells. So here, this is a co-culture experiment. Our cancer cells are red, so they're stained with dye. Our MSCs are green with their GFP. And if we look at just the red cells in co-culture, we can see them undergoing apoptosis and death. And this is controllable by the doxycycline compared to the no doxycycline. So Michael then did some more experiments just to make sure that it was indeed the TRAIL that was killing the cells. So here's our MSC doxycycline. This is a recombinant TRAIL which we sourced. And actually, this is always borne out in our experiments that TRAIL expressed on the surface of MSCs tends to kill more cancer than recombinant TRAIL. And this is a neutralizing antibody, so we see some reduction with the neutralizing antibody. And similarly, we've used a dominant negative FAD construct and a caspase inhibitor, again, sort of blocking the 2 pathways to extrinsic death pathway and apoptosis. So his next experiment was to see whether cells actually get into the tumor. So you can imagine a year into his PhD, this is a bit of a crunch experiment. And it was probably one of the experiments I remember seeing the result of most in my sort of 17 years, I guess, now as a PI. So this is a metastatic mouse lung model. These are actually MDAB cells. And here's our H&E. So we can see a metastasis here, a little one here, perhaps up here. And this is the low power model, so you can see metastases scattered throughout the lung. It's a really, really nice model. And it's difficult to see with the lighting, but I'm sure you can make out. Here's our 24 hours after injection of dye-eye stained MSCs, you can see them localizing into these metastases. And I hope you can see maybe just about the red cells all localized in metastases. So it really did bear out that original glioma data. So his final experiment was, of course, to see whether it actually has an effect in a mouse. So these are xenograft models using human MSCs, human cancers in a non-skid mouse. And basically, we had three groups. So here's our no-cell group, metastasis number by total area. These are our MSCs with no doxycycline. So I just go back to that slight bleed through. We think that there might be a slight bleed through of trail in these MSCs because there also seemed to be a significant reduction. But you can see with doxycycline, we see a dramatic further reduction in the cancers. So at this point, we also became interested in mesothelioma. So Beth Sage joined the lab, and Krish Kalluri, who's a basic scientist and has kind of knitted the whole program together. Beth was really interested in mesothelioma. Mesothelioma is quite a challenging disease. It's extremely resistant to pretty well everything, as you've just heard. It's also actually on the other side of the circulation from the lungs. So the cells that we deliver that get wedged in the lung will not treat mesothelioma because they're on the wrong side. They've got to recirculate back through the heart to eventually get to a mesothelioma, which is in the pleura, before hopefully delivering the therapy. So Beth did a lot of work setting up similar experiments, testing in vitro whether these cells would affect mesothelioma cells. We developed actually quite a nice story alongside. We actually worked out that probably about 60% of mesotheliomas are actually highly sensitive to trail, and that's related to a molecule called BAP1. But nonetheless, at this stage, Beth was sort of looking at trail effects. So we have, I'll go back. So we have recombinant trail here. So these are trails. This is a trail-sensitive mesothelioma cell line, our empty MSCs, and then again, our MSC trail outcompeting the recombinant trail. So the first thing Beth had to do was to set up a mouse model. So we didn't have this mouse model, actually not many mouse models of mesothelioma. And what we do actually is directly inject mesothelioma cells into the chest. We say it's pleural space, but obviously it's done blindly. But the cells probably actually do settle into the pleural space. And then we were delivering the MSCs either again directly into the pleural space or through the tail vein. And now we're using luciferase to track our cells, so we can see our cancers here at the top, and then our MSCs at the bottom. And slightly gruesomely, when you open up the thoracic cavity of the mice, you can see quite good localization, both with pleural injection of the MSCs and the intravenous injection, matching the mesothelioma. So Beth's first experiment, we were really keen on direct injection of MSCs, and you've heard this from Prasad. Patients often have a pleural effusion, which means we can place a catheter into their chest. Many patients actually walk around with little catheters in their chest, and we could potentially keep delivering these MSCs. So Beth delivered 5 lots of MSCs this way to these mice. However, what she found was there was no difference in the tumor formation. However, when she then went on to look at the systemic delivery of the MSCs, what she found on this occasion was that there was indeed a reduction in tumor growth. And she measured this both by bioluminescence and lung weight. So one of the things that we thought was interesting, we were quite disappointed actually. We really liked the pleural delivery, and we think actually it's just a dose issue. So when we actually extracted the cancers from the pleura with pleurally derived MSCs, whilst we could see co-localization, only about 0.5% of the tumors were made up of the MSCs, whilst after intravenous delivery, we have around 3% of the tumors made up of the MSCs. So meanwhile, in the lab, a Chinese postdoc had joined, and he was really interested in using solubilized trail. And actually, this had been used in a couple of other labs around the world. So he made a construct which was basically a solubilized shortened form of trail, which had an isoleucine zipper, meaning it could trimerize and potentially be secreted by cells into a tumor microenvironment. And this is awfully complicated, but I'm going to just draw out a couple of things. So this is 20 lung cancer cell lines. And what Chang's done here is he's divided them into trail sensitive in the top left, moderate, low, and then resistant. And that's all done by the activity of recombinant trail. So you can see here recombinant trail is killing up to 80% of these cancer cells. This is matched by our full-length trail, but you can see our solubilized trail actually really didn't work at all, which was quite disappointing. Interestingly, now, if we look at the resistant trail non-small cell lung cancers, you can see here, so we've got recombinant trail with resistance. Again, our solubilized not working, but look, our MSC expressing full-length trail seems to overcome some of the resistance to trail. So why is this? Well, unfortunately, our lab didn't discover this, but it's a beautiful discovery and beautifully shown in this paper. What is felt with full-length trail is that you get these sort of higher-order clustering complexes of trail on the cell surface. So you basically get these huge lattices of trail triggering cell death into cancer cells. And the final thing Chang did before he left was he also gave us our data showing that original idea that triggering the extrinsic death pathway with the intrinsic was potentially a great idea. So this is trail-resistant non-small cell, one of the cell lines that is resistant to trail. We can see our MSCs having, that's our sort of control level. Our MSC trail is causing some cell death. This is the chemotherapy we use in the clinic, cisplatin pemetrexed. You can see how miserably rubbish it is. I mean, it really doesn't work very well, as pretty well borne out in the clinic. But look together. They really do work beautifully together. So we applied to the MRC, the DPFS funding scheme, for the trial called Tactical, which is a phase 1-2 trial to assess the safety and efficacy of MSC Trail in combination with standard of care therapy. So that standard of care therapy turned out to be good that we said that in some ways, but has caused quite some problems for us over the last 5 years. The eligibility of patients into the trial is that they have to have incurable lung cancer. They can't be potentially curable with surgery or radiotherapy or a combination. It's a first-line treatment. And also in lung cancer, we have 2 molecular therapies against EGFR and ALK, and actually there are a couple more now. So our patients should be negative to these. They shouldn't be going on to these molecularly targeted therapies. No brain mets, good performance status, and no history of blood clots. So phase 1 was a single-center study. It's academically run. Huge thanks to King's, who made our virus for us. Adrian Thrasher's team did our transduction. And then the cells have all been grown with Mark Lodell at the Royal Free site. The plan, or what the study is it's a dose de-escalation design because we knew basically what we could afford to deliver within the cell envelope, so we knew we couldn't increase in doses, so it was we chose a dose de-escalation design. And basically this is what we give to patients, so they get their standard of care treatment on day 1, and then day 2 we give our MSC Trail therapy. You'll again note our patients tend to get 4 doses of chemotherapy as a standard treatment, and we're giving 3 doses of MSC Trail. And again, this was decided pragmatically, actually, to fit within an affordable window, which we felt NICE would fund. So primary endpoints, secondary endpoints, I won't dwell on these too much, but primary endpoints, obviously, for the phase 1 is dose-limiting toxicities and deciding on the phase 2 dose. And phase 2 is randomized, so we have a control arm and an investigational arm. Phase 2 endpoint being tumor response rate at 12 weeks. So there were 2 major hitches over the last 3 years. So we opened our phase 1 about 3 years ago. The first was that the starting material we started out with was bone marrow-derived MSCs carrying trail. And basically, Mark Lodell's team showed that these cells were not expanding rapidly enough in the bioreactors that we were using, and therefore we had to switch to an umbilical cord source of material. So we had to go back to the lab and show equivalence of the cells. It took us about a year to 18 months, and then we were able to reopen the phase 1. And basically, so the source material now is an allogeneic product made up of 7 cords. The manufacturing, again, I won't go into this too much for time, but they are isolated from umbilical cords, lentivirally transduced, and then we have a primary seed stock, a working cell stock, and then the product, which is frozen down and delivered to the patient bedside. And this is then thawed by the nursing team at UCLH and delivered over 45 minutes. So I've just got one patient to give you a feel for the type of patients that we are delivering the cells to. I don't have any results, however, but this is a 63-year-old ex-builder. He has a 30-pack year history of smoking. Mother had lung cancer, living with his sister, PS1. And this is what his scans look like. So he largely has a right upper lobe cancer, and he also actually had some mediastinal lymph nodes. He went through his treatments, MSC Trail with chemotherapy for 3 cycles, and then finally a chemo immune checkpoint inhibitor alone. So this was the second big stop for us, of course, because all our preliminary data was with chemo alone, but chemo checkpoint inhibitors became the standard of care choice. So again, we had to go back to the laboratory and do some translational work for the MHRA before we could continue with immune checkpoint inhibitors. What I will show you today, though, is some data from the patients that's not outcome-based, but it is some translational data. It's the first time we've shown it. And this is Rebecca Graham's PhD, and she's just literally writing up and doing her viva at the moment. So what can we say about the cells when we deliver them? Well, we can say that we can actually see them circulate for about 6 hours, judging by the sort of detection threshold of looking for the plasmid in the circulation. So you can see here spikes after delivery of the MSC Trail for 3 and 6 hours. And actually, after the second cycle, we see similar spikes. But we see nothing circulating after 24 hours. Do we see any signs that the MSC Trail is working? Well, I don't think I can really say that to you at the moment because we don't have the right controls. But one thing we've been measuring is circulating plasma CK18 levels. So this is just a sort of epithelial cell death monitor. And what we do see are spikes after delivering the MSC Trail cells in a number of patients. But of course, they were also getting chemotherapy and immune checkpoint inhibition 24 hours before the cells. So currently we're taking some bloods from people that are just having their chemotherapy and immune checkpoint inhibition. What do we know about the cells? Of course, we use MSCs because we think that they're not rejected when we give them. And what we show is that they do indeed lack expression of MHC class 2 and co-stimulatory molecules. So here is our class 2, and CD80, CD86 are lacked on our MSCs. So we're thinking that this gives them protection from rejection, but do we have any data on this? So I'm very pleased to say we've been working with Joanna Jones at Cambridge on this, and she helped us set up these assays whereby we would take basically PBMCs day 1 or day 2, so these are pre-MSC Trail delivery, and then day 15 cells, so they've clearly been exposed to the MSC Trail. We get the actual drug product, and then we mix the PBMCs from days 1 and 15 with the drug product for after cycles 1 and 2. And what we see is absolutely no evidence that there's a detectable immune response in these patients. So our day 15 after cycle 1 and cycle 2 might be where we would expect to see these PBMCs either activated or proliferating. So we don't see that, suggesting that repeat dosing of this type of therapy is possible. The last thing that, last little piece of data, which we don't really understand, but we think is quite interesting, is we appear to see a sort of cyclical depletion of monocytes. So again, this is something that I've not found any data on published from immune checkpoint inhibition or chemotherapy, but what we see is this sort of dip at day 8 in monocytes after dosing, so we're unsure whether this is due to the drugs or the cell therapy. But what we do see is that these monocytes that remain at day 8 seem to be ones with an antigen-presenting or anti-tumor CD40, CD86 phenotype. So potentially interesting, but again, we need some more controls. So in summary, what I think I've shown you is that MSCs do appear to home to tumors. So we really do believe that they have potential as an anti-cancer treatment, anti-solid tumor treatment. They can deliver anti-cancer payloads for sure. They appear safe to deliver intravenously. They circulate. We've got evidence they circulate for 6 hours. And what this means is that potentially they may also detect metastases outside of the lung. Allogeneic MSC trail doesn't appear to elicit any sort of immune response, meaning that you can potentially keep giving them in new doses. And they may well work well with concurrent treatments. So just a few other slides. So this is other people's work and trials that are published. So the use of MSCs carrying a sort of genetic payload is being used by other teams. And probably the most famous one is this one, which is the TreatMe-1 trial. So this has been published. And so highlights of this and differences, actually. So this is an autologous genetically modified therapy, so much harder than our sort of off-the-shelf allogeneic therapy. It delivers HSV-TK to GI cancers. Again, really difficult cancer to choose, actually. They're very rare. This was upper GI cancers. And it turned out to be safe and well tolerated. No apparent change in tumor size, just in the phase 1 of that study. So a huge thanks. I'll thank Krish, Alice, Rebecca, and Beth, and Chang in particular, who I've mentioned today. Of course, Michael kicked off all these studies. Joe Jones has been instrumental in helping us with some of the immune rejection work. And to measure the team in particular, Martin Forster is our chief oncologist and the CI of the trial, Mark Lodell, and Ben Weil do all the cell manufacturing. Adrian Thrasher I've mentioned, and our TRO have been hugely helpful. And then, of course, our trials unit, particularly Alex Day, who's been running the study for us. Thank you very much.